Okay, we come to the topic of a complex bifurcation stenosis, obviously. And I would like to show you a little bit, is it right? How we can handle that surgically. And I must say there is not a big controversy with the interventional cardiologists, because I think in this field we are really complementary. But I would like to show you how far the surgeon can go with maybe a not too bad solution, because it is always a difficult situation to do with those patients. What we like to operate, obviously we like to operate any primary correction, and especially those, our favorites are the arterial switch operation, Ross procedure, fallow, canals, coarctation, because here, I mean, when we have a successful result, we feel like a little bit James Bond. We know we have changed something in the lives of those patients. I know we cannot use the word curative, but at the end we have the impression we are curatively palliative in those situations. What we don't like so much are MAPCAS, unifocalization, peripheral stenosis, and surgery in multiple redo. It's difficult to do. We don't get such a good results, and it's a little bit frustrating. It's a long, frustrating operation, difficult dissection. We work in people surgery. It's deeply positioned structure. It's a fight. It's a back breaking operation for us. For not a dramatic result, we have residual or recurrent defects coming very soon with bleeding problems, high pressure in the right ventricle, and we end up with this very strange feeling to have merely pushed the same troublesome problem for only a few years ahead. And this is a hot potato, and if we can give it to you, we would not hesitate to do it, I must say. So we are only palliatively palliative in those situations. Now, back to the bifurcation. I mean, what is the role of the pulmonary bifurcation? It balances the perfusion to both lungs. And I must say, as much as I can, I preserve the bifurcation here. It has also a good potential for the regrowth or the growth of the pulmonary arteries, especially in pulmonary atresia. If we can put something here connecting either to the aorta or to the right ventricle, we will at least profit from the distribution of blood in both lungs. And if we're lucky, if we do that soon enough, we might have harmonious growth of both pulmonary arteries. Those are the two techniques. Either on the pulmonary artery here, we favor the pressure here, or on the infundibulum, we prefer the pressure difference in those situations, which is also a good stimulus for the growth of the pulmonary arteries. And it is very important for us, anytime we operate, to try to preserve the bifurcation. I think at the Ross procedure, this is here the pulmonary bifurcation, and this is what we see in books, for instance, for the Ross procedure. In my opinion, this is not correctly done. If you do that, you can put an homograph, you will be sure you will have a kinking here and probably a stenosis at the beginning of both pulmonary arteries. You really should cut it much higher here and have at least 1 or 2 millimeters or 3 millimeters of common trunk to preserve the bifurcation. The arterial switch operation is the same. I'll show you an example. Truncus arteriosus also, we do not have so much liberties there, but we often can do something on the bifurcation, and also the tetralogy of fallow, for instance. I never do a transannular patch down to the bifurcation. I usually stop before the bifurcation to preserve that. This is an arterial switch operation, and you can see cut it here, and then I come as close as possible to the pulmonary valve here, 1 millimeter above the sinotubular junction. And by doing this, I will have a bifurcation that can be used later on to finish my switch operation. So what are we doing with the diminutive bifurcation or proximal PA stenosis? I think there are still clear indications for surgery. Anytime we can make the repair, another repair with local and living tissues, because they will grow and they will not present all the problems that we have with patches. And anytime the dissection is also feasible. I mean, we are afraid of reduced procedures because everything is frozen. And when you come for the second time or third time, just forget it about getting into the pulmonary hilum. It's simply too difficult to do that. And also, we can operate on the intrapericardial PAs, but as soon as we get outside of the pericardium, it's almost also technically extremely difficult, if not impossible. So clear indication, I think it's a bifurcation stenosis on otherwise normal PAs and proximal stenosis of the PA. And I'll show you now example how I deal with that. This is an example here that we see sometimes after truncus arteriosus, or even after some kind. We have a stenosis here on the beginning of two pulmonary arteries, and also the bifurcation is hypoplastic. What I do in those cases, I dissect the pulmonary arteries very far down in the hilum, just like for a switch operation. Remember, a switch operation will bring both pulmonary arteries, which are very posteriorly, anteriorly, or above the aorta. And if you do the dissection very far away, you will gain length, and you will be able to do that. I try to gain as much length as I can, and you can see that you gain this length. Then I take here this part, and I bring it to this one, making a kissing pulmonary arteries, and I mark the point where I have start to have some tension. When it is finished, to do that, I mark the 2 points here. I cut here the bifurcation. From the bifurcation, I look at, from the pulmonary trunk, sorry, I look at the bifurcation, and from the inside, I cut it here, and I cut it there. This brings like that, but this has been cut, sorry for the drawing here, and even more lateral. And then I bring this part here, still working from the pulmonary trunk, I bring this part here to this one. And indirectly, I will increase this diameter here, and I will increase this diameter here by having something like that. Actually, I'm pushing the bifurcation posteriorly. This is what I call a posterior bifurcation. But to do that, you really have to dissect the pulmonary arteries very much, because you have to gain tissue here, and I like it, for instance, when I have stenosis, and here something like a bulging artery, because it really allows you to do that. Second thing is I still work here, and I put a contegra, whatever here, I don't try to make a big oversizing, and this is exactly the situation where I do interrupted sutures there, endothelium to endothelium. We can also do that here, and usually it works very well. I have a case, I didn't bring it here. I don't like anecdotes, but still I can tell you, or even remember that he had been operated. She was a lady, a small girl, 3 times at 7 months with an aortic homograph, and the pressure on the right ventricle was still suprasystemic. And she came to us, and I did exactly that. She went later on in Germany, and she was followed by John Hess, and he sent the patient back to me for the first replacement of the contegra after 8 years. So it was really a very satisfactory correction on that. If we had only a proximal PA stenosis, this is what you look in books. First of all, also, when I have to enlarge an artery, I usually, when we operate, we'll see the anterior part of the structures. But I go on the curves. I would do it here, not here, not here, and not here. I would do it here, and I would do maybe it here, along the curves again. So not really there, but also underneath here. And you can put a patch here. Then you have to increase to the opening here. You have to resect something here. Otherwise, you might have still a stenosis just by the recall of the tissues. And then you can reimplant your right pulmonary artery to the pulmonary trunk here, or bifurcation. On the left side, this is what the drawings or what the books shows. I must say we frequently have a problem by fellows here. I personally open up on this side here and try to make the same plasty I showed you. If you have to put a patch, okay, you can put a patch, but like that. And I try to make exactly the same thing here. I open up here. I try to bring my tissue here to mobilize a lot. And then at the end, I bring it like that, and I avoid any additional tissue here. And I can increase the opening of the left pulmonary artery. So the diminutive bifurcation, what is troublesome for surgery? This kind of bifurcation when everything is small, but there is not much you can do. Or you can put a patch here underneath and to the hilum, or here underneath to the hilum. You will gain a few years, but then the problem will still be there. And nobody is very happy with those situations. Also the distal PA stenosis. As soon as you are here, and so surgery is so difficult that we usually leave it to our cardiologist colleagues. sides. And distal stenosis also in redos, we have the problem. Now, there is also something that we see in a few patients. It's a compression of the PA, of the pulmonary artery by the aortic root or the ascending aorta. You can put a patch. The compression will still be there. And it's difficult to reduce the size of those because we're usually at the root. And if you try to diminish the diameter, you might disturb the fine architecture of the aortic valve. And in those situations, I think for me, those are indications for cardiologic intervention. And when you have a proximal stenosis of PA after many surgeries, for instance, the distal stenosis, and also the compression of the ascending aorta on the right PA or left PA. And the typical examples are truncus arteriosus, because in these situations, the truncal root is very big and can compress. And the second classical indication is after a no-root procedure, because we have increased the fusion of those two roots, and it also compresses what we call the left pulmonary artery, but actually it's the segment of the right pulmonary artery deviated to the left on those patients here. This is an example here. Here, I must say, I'm very happy when the cardiologists come and put a stent inside, because it will be extremely difficult to, you can put a patch, and maybe you can put it underneath or over here, but if you put it anteriorly, the aorta will compress on it, and you will not have any result of that. So, and when the patient is bigger, and so you might be able to re-increase, to make a plasty here when you do, for instance, the last step of the cardiopulmonary anastomosis. The trouble with patches is it's not a living tissue. It's often stiff and thicker than the pulmonary artery wall. Remember, we call it a pulmonary artery, but the wall is the wall of the vein because the pressure is very low. And usually you should have something homogeneous, so the patch should not be very bigger or stiffer than that, and we hardly have that at disposal. They are prone to distortion, and especially when we operate, we pull up subtractions and so on. When everything goes back down, then folds can be created inside the vessel, and it shrinks with time. And sometimes the shrinking creates a secondary stenosis, which was not there before and comes later on. It creates a local scar, which makes any surgery or any other intervention much more difficult later on. It calcifies. And again, it's very difficult to reoperate, but it's also difficult to dilate. So we have to be careful with patches, especially if we go very peripherally on the pulmonary arteries. For me, the choice of patch, if you have a good autologous pericardium, is still the best, I think. Sometimes you can tan it. Sometimes I prefer it without glutaraldehyde, but it's often not available, because if you redo surgery, your pericardium is no longer so nice. It's thickened, and it's not much better than a seno-pericardium. Pulmonary homograph for the pulmonary arteries is certainly very good, but the problem, we don't have so many at hand, and it's also sometimes difficult to handle, to find at least a good segment to do a nice plasty. And xenopericardium, this is what we're doing today, what we're using today. It's prone to distortion, calcification. I must say, personally, I take the matrix patch because it's very thin, very pliable, and use 8-0 needle to do that. It's very time-consuming, but at least it gives good results at the very beginning. When will we have tissue-engineered patch, which will be living tissues and will solve all the problems? It will be a big step forwards if we had that. It's promising, but at the moment, it's still only promising. I hope it will be different in the future. Again, the trouble with stents now, from the surgical point of view, because we have to reoperate sometimes with stents, the vessels are much more rigid there. The caliber change is limited by the stent. You can dilate it once or twice, but you seldom come to an adult size. And it is relatively rapidly, after a few months, 3-4 months, incorporated in the arterial wall, at least when you are on the side branches. And usually you cannot retrieve it anymore because you will take off everything on those, and you have to cut it. But it is possible to cut it. You still have to get good scissors. You can cut it, spread it, and put a patch to enlarge it. So when you saw this patch on the pulmonary artery going to the left side, when you do the cardiopulmonary anastomosis, you can still enlarge it later on. So it's not really something impossible to work on. By the way, when it is on the infundibulum, on the main pulmonary artery, we can retrieve it with, usually you find the plant to retrieve it, but not in the side branches. And sometimes it impinges on the bifurcation, especially on the left side, for instance, because you don't have so much place here. And when we reoperate, sometimes it's amazing to see, you know, the stent bulging out in the main pulmonary artery here. So still, it's difficult to enlarge surgically. So I don't have many conclusions. I didn't have time for that. I just took the take-home message of Gerhard from Köln, and he said, well, successful treatment in these difficult cases is only possible when surgery and interventional cardiology work together, and I really do think it's like that. But I like it that the cardiologist showed me all the cases and we discussed, because sometimes we can come out with something like I showed a living kind of repair, and then my approach might be better than a stent. And there is no ideal material, no stent or no patch, and so, and the incidence of reintervention, in spite of all our efforts, is still there and sometimes high. Thank you.